And yeah, I mean, and it is amazing. Every time I go there, it gives me goosebumps to realize how a man with just his intellect and commitment can change medical history. So, see, when I used to work at the Cancer Institute in Chennai, and all my thoughts about healthcare are what I learned there. And poor people. So I used to think people in Chennai are poor till I came to Assam. The amount of poverty in many parts of our country and many parts of the world for that matter, there is no limits to it. And when poor people are are facing a healthcare catastrophe like a cardiovascular event or a stroke or cancer, they don't have money readily available. And so what they do, they resort to distress sales. They will sell everything that one can conceive of, their houses, their cattle, the trees in their house, the roof in Assam, lot of because of the rainfall, we have those Assam style roof where the roof, one layer is tin over which there is a lot of, and so they will sell the tin during the winter months, thinking that by the time the rains come, they would repair the roof. And then only, because of it is of a cancer, many times they will lose their patients, they will lose their money, they will lose their roof. And it's a difficult life for many of them. And then they will resort to borrowing from local money lenders at exorbitant rates. And then they would take a begging bowl and expect charity from the healthcare provider, from family, from friends, all in a desperate bid to access treatment in order to stay alive. But then finally, many of them will simply find the easiest way out, that is not to access treatment. They will go back home and just accept that their, fate is to live with the cancer and die of the cancer. And so our initial thoughts were also, if I tell my story now in retrospect, it looks as if we had a organized game plan and we put in place all the building blocks. But actually, we did not have any idea. We did not know um, the problems individuals face. And all of what we did was pretty much firefighting. We would find a problem, address it, and move on. And to this day, that is how we've been functioning. But then broadly, when I look back, organically, we resorted to a few strategies. For one, we actively branded ourselves as pro-poor every opportunity we get. We adopted a whole lot of cost reduction strategies. We realized that time is of essence for many of them, and so we fast forwarded workup and treatment schedules. In the initial years, I was very skeptical of technology because I used to think it will add to cost. But now I think technology is a great game leveler. And then we put in a lot of effort trying to ensure that the access to care is available, and then people actually accept the care that is provided. So initially, we started off with just providing pro-poor. We gave low cost or no cost treatment, boarding and lodging. We made sure that our whole the infrastructure, the facade, everything reflects the pro-poor strategy. We don't want fancy looking buildings with marble and paintings and fountains because those would intimidate poor people. When a poor person stops us on the corridor, we have to stop, address that issue and move on. One unkind word and they will simply disappear. The other thing is we've often been told, that we can charge more money from people who can afford and use that to write off costs for poor people. Long ago, we took a decision that we will not have dual pricing for people because, when we have a rich man who is paying for care, they will naturally expect better services for to add value to what. So they will want the senior most doctor to see them. They will want to be seen in separate enclosures. They will not want waiting time. They will want, and the treating physicians, I as a doctor will also feel justified in catering to their needs because I will also think that. These people are subsidizing the cost for people who don't have. But the tragedy of the whole thing is the poor man who has come for treatment will also start believing that it is okay for the rich man to be treated better and treated earlier and given priority, and for them to be, seen by less qualified doctor. And so that is something we don't want. Everybody deserves the same quality of care. And so we don't have dual charges. Many of my staff multitask. They, on one hand, they will be a physician, or they will do endoscopies, they will talk to patients, they will go into the community, reducing the cost burden of salaries. And then we have a policy. Initially, this was with the idea of reducing costs of nursing. We said every patient will have a caregiver permitted officially to stay. Even our ICUs are open ICUs. But now we realize, on one hand, it is logistically, economically safe and sensible. But on the other hand, emotionally also for the patient to have a known caregiver with them is a huge confidence building measure. And then we make sure that we don't have any hidden costs. We say the cost of treatment is 10 rupees, it has to be 10 rupees. It cannot be, there cannot be service charges and additional charges. But with all of this, in 2010 we got a grant from the Indo-American Cancer Center, from the Indo-American Cancer Association the- in uh, in Texas, to start a division of palliative care. And as a follow up, we had to make a report to them in their annual meeting in Kolkata in 2011, and we found that only 30% of our patients were accepting oral morphine. At that time, it did not impact on us because we thought these are all patients with advanced cancers and they are not coming back for treatment because they come from far off places. But we thought that people whom we were treating with intent to cure, we were giving low cost treatment, boarding, lodging. We were under the impression that they're all doing very well. When we came back, we actually audited this thought process, and to our astonishment, we found that nearly 60% of patients did not even come for a second hospital visit. And of those who came for a follow-up visit, only 28% completed treatment, meaning all that we were doing was just a waste. We were not changing anybody's lives. And then we sat thinking, I asked my colleague Amit to find out why this is happening. And then after several months, he came back and told us that most of our patients, even today, that's a fact, almost 80% of our patients work for daily wages. No benefits. If they don't earn for a day, there is no food at home the next day. And so often when the breadwinner has to keep coming back to the hospital for himself or herself or for a family member, the rest of the family starves. And so they just drop out of treatment, often a cruel but necessary decision. And so we put in place a number of measures to see if we can help out of this quandary. And so we said, oh, they are coming, they are daily wage earners. We said we will provide ad hoc employment on campus. We said they are coming. We wrote out a software where if I open today's date, all the patients who are coming for review today, their names will be seen. And as we see them, the names disappear, giving us a list of people who have not come back. And then we get on the phone to call them up, or we visit their homes and we put in place measures to see how we can improve compliance to care. And then we made sure that we don't have waiting lists. And so, for example, our pathology department, see, if you take a biopsy, typically biopsies will take 2, 3, 4 days for a report to be ready. And because the thing is put in formalin, after 8 hours, it is processed, it is put in a paraffin wax, it is cut. It takes time. So we changed our whole pathology reporting system to rely on frozen sections. So our strategy is patient comes to the OPD today. Same day the blood biochemistry, X-ray, ECG happens. Next day morning they have their endoscopies or whatever and biopsy, and then they go and have their imaging done, CT scans or whatever. All the pathology reporting is on frozen section. So by the time the patient comes in the afternoon, the diagnosis, the stage, and the treatment plan is ready. And then they will go back to decide how. It also gives us time to look around for resources to support them. Then we worked, if the government of India was looking for looking at the Department of Ministry of Information and Technology was looking at a telemedicine software to be implemented in the Northeast. So they chose the local NIT as their implementation partner, and the local NIT chose us to be the hospital to work with them. And so, as part of that, we opened satellite centers in two of our neighboring districts. Initially, what used to happen is all the home visits used to happen from Silchar, and so somebody will get into a vehicle in the morning and travel the whole day, about 200 kilometers, just to see one patient who has not come. From a public health point of view, from a cost economics point of view, it doesn't make any sense to go and see one patient. But from a hospital point of view, it is very important that we don't miss out on any. Every sparrow has to be counted. So somebody will go visit the patient in their homes and then come back. By the time he or she comes back, it will be late in the evening, and our admin officer will be out on the street. I think what happened? These people have not come back, and so and then we opened satellite. Now what happens is all the home visits for the districts happens from the satellite centers in Karimganj or Lala. Government of Tripura has now given us 15 acres of land to replicate the model of our hospital in Dharmanagar in North Tripura. And so we are trying to get into the different districts, put up smaller hospitals to improve access to care. And then in 2015, we got a grant through. So what happens is each time we get a research grant, we put in place some equipment, we recruit some human resources, and then once the project is over, we continue with the thing. And so slowly the hospital grows. And then we realize that, sometimes, patients don't have, we say we need to have a check endoscopy and follow up. Every time if they have to pay for endoscopies, they will not go and have it. So we removed all duplicate charges. Initially, for our OPD consultations, we were charging 100 rupees valid for a month for any number of visits, any number of doctors. We realized every month if they have to give 100 rupees, it's a disincentive. So quickly we did our math and said, let them pay 500 rupees one time. And after that, for a lifetime, there is no further charges. Immediately, the compliance improves in the hospital. Patients come back in the satellites, patients come back and report. And so, over a period of time, we put in place cost reduction strategies. A couple of years ago, we actually, for me, the ad hoc employment was a winner, and I thought that is going to make all the difference. So actually, a few years ago, we audited the impact of providing employment, and we realized out of about 3,000 patients who were treated, we had provided employment to only about 20-25 patients, which means the impact in terms of completion of treatment was far more than the employment that we provided. What we now realize is each time, when we waive off charges, when we say there are no duplicate charges, when we say we will reduce waiting time, when we visit their homes, when we offer, many of them will not accept the employment. But despite that, I think all of these are basically confidence building measures. When all of it put together adds to the trust in the hospital, and that improves compliance. Trust building, to my opinion, is a 24 by 7 exercise where every time there is a situation, we have to prove that we are trustworthy. The other thing we do is, task shifting. So our lung biopsies, for example, are all done by trained technologists. And then for a brief period in between, we had a radiologist who started doing them. When we compared the biopsies performed by the radiologist and performed by the technologist, in terms of representative tissue and in terms of complication, there were no difference. And so, uh, uh, task shifting improves access to care, reduce costs of treatment, and so several things happen. And our current strategy is, a large majority of patients are able to have their treatment planned within the first 2 days and are able to start treatment within the first 7, 10, 15 days. Technology is a great leveler. See, we don't have an ICU trained physician, critical care specialist, and we are unlikely to get critical care trained doctors in the next 10 years. The whole country does not have enough numbers of them. And so, what we did is we teamed up with a team of critical care specialists sitting in Bangalore, and we put these high definition cameras in our ICU has 15 beds, and each patient is seen by a camera and the monitor is read by the camera, which translates the monitor readings into a paper document. And each patient is watched 24 by 7 by a team of doctors, nurses sitting in Bangalore on a virtual platform. And believe me, cloud ICUs save lives. We've had patients who have arrested several times, who have been revived with the support of the cloud physicians and are on follow up. Several times this morning, we had a patient who was operated 4 or 5 days ago, who suddenly developed an MI, who's being currently treated, stabilized, and I'm very hopeful that she will go home. And so, and then pathology, for example, we have 1.5 pathologists, now 2.5 pathologists, but our volume of pathology is so much that it is not, they find it very difficult to cope. So, we got a slide scanner from Tata Trust and we are teamed up with a team of pathologists sitting in Hyderabad. Slides are prepared and transmitted, and within 6 to 8 hours, the report comes back to us. Same way for it. So everywhere, using technology, and then we also have to be frugal in our innovation. So we don't have uh, uh, when specimens are fixed in formalin, we don't have a grossing station because grossing stations cost 2.5, 3 lakhs. And so one of my colleagues suggested, why don't we use a kitchen chimney to fabricate a grossing station? And so that's what we did. We put a kitchen chimney and you put a specimen on the table. Not a whiff of formalin is smelt in the lab. Everything is sucked by the kitchen chimney and so on out. And then COVID taught us a whole lot of things. We started Zoom calls in order to support our COVID program with the National Cancer Grid. And now Zoom has become a platform where a lot of teaching learning happens. And throughout the week, something keeps happening. We work extensively with the community. And one of my colleagues wrote out an app on a mobile software. I will talk more about it, but the ASHA in the community are able to use it. All our satellite centers are linked on an IT backbone, and somebody sitting in the hospital can talk to patients and caregivers sitting in a satellite center elsewhere and actually prescribe even chemotherapy happens like that. The other important thing for us to remember is as hospitals, we must never falter on access. Patients take a lot of trouble to come to the hospital, and at the end of the day, we cannot say, oh, there are no more appointments, you go back and come tomorrow. They've taken time off, they've traveled, they've spent money, they're losing wages. And so, our policy is anybody who comes to the hospital must be seen the same day. We never turn a patient away. It places a lot of stress on my own colleagues because they end up spending long hours in the outpatient clinic. We're trying to see how we can, add additional forces later in the evening to mop up all the patients. See, because we live in a difficult to access region, most patients will start arriving only after about 11, 11:30 or 12, and the peak crowd invariably happens in the afternoons, but they will come late, but they will want to go immediately because they have to get back home. And so it's a difficult challenge for us. The other thing is when we are hit by floods several times, our my colleagues, fashion rafts on which we transfer patients, on which we transfer cylinders. And thanks, to my colleagues, their spirit during the COVID years, also during natural calamities, also we have never had to close the hospital even for a single day. The responsibility of keeping the hospital functioning all the time is very important. Then the community activities, initially we realized long ago that if we have to be accepted as a hospital, as a healthcare service, we need to win the trust of the community. So apart from what we do in the hospital, we also have to go out into the community to be able to interact with the community, to be able to build confidence in the community. In the initial years, we used to do a lot of awareness and screening randomly, and very quickly, we realized that these screening camps we get kids as young as 3 months, and we get people as old as 85, 90 years, and we were not achieving anything through these screening camps. So around 2013, we put an end to all these community activities. In 2016, the government of India came out with screening guidelines for NCDs and some cancers. And according to their guidelines, the ASHA in the community will mobilize, they will act as community mobilizers to bring them to a sub center where an ANM was to screen them. But we thought that this is a difficult model because the ANM is responsible for about 5,000 population and she has 100 jobs to perform. The ASHA, on the other hand, we did a time motion study and we found that for a working month of about 22 days, 5 hours a day, they're actually engaged only for about 12 days. And so they are able to, potentially, they are able to give time. And so the ICMR came up with a project for testing the government's model in Tripura, and they came to us because the cancer center in Tripura at that time was not ready to do it. And so we tweaked the project and we said that we made two changes to the guideline. We said one, the screening will be done in the homes of the community, and two, we said it is the ASHA who will do the first level of triage examination. Lot of opposition to the ASHA, not capable of doing it. They are not capable of learning. We had to answer, will the Asha be willing to do it? Will the Asha be capable? Will they be able to do it? Will the community accept the Asha in this role? And can screening at home be actually feasible? And when we finished, in one health block, we reached out to about 50,000 people, more than 45,000 people, more than 90% of the population complied with the screening, an almost unheard of situation. And we were actually able to show that the Asha were capable of doing it, willing to do it. Community acceptance was very good, and that screening at home was possible. Out of 46,000 people that we examined, we picked up 40 cancers and about 100 pre-cancers. Then, we thought this was a very labor-consuming activity. So in another district, again with support from the ICMR, we ran another project wondering what happens instead of door-to-door physical examination if we were to create a blitzkrieg of information and encourage self-referral for evaluation. And we actually did similar population. We reached out to about 45,000 individuals and uh, about 4,000 of them self-referred themselves. And out of these 4,000, we picked up 102 cancers and nearly 800 pre-cancers, mostly of the oral cavity. Then we said that if just the health department does awareness, the outcomes are so much better.
Sorry
What
to
happens?
interrupt, Dr. Kannan, but there are multiple slides showing on the screen. Is
Yeah,
that how
this
you
is,
want it?
yes, ma'am, because
Okay.
I didn't
All
want to
right.
go through each of them. This is
All
just to
right.
show how this progressed.
All right. Thank
So, so we we are now working in Lakipur, where we are having several departments of the government, the health department, education, police, Anganwadi workers, fair price shops, everybody contributing to awareness, trying to see if it will improve awareness and more people will self-refer themselves for evaluation. And then in Dhima Hasao, which is a hill and forest district, we are now scaling up what we learned in the first two projects. We are saying that the ASHA will continue to create awareness, but of those who self-refer themselves, the ASHA will do the first. So we're using the learnings of both the Katli Chera and the Dhalai projects, to try and see if we can scale up this model to show that this could be one of the models that can be implemented across the country. The other thing that we are also doing is, we're very excited by this. We have a very aggressive home care program where this is basically for people for palliative care. And what happens is when we go to homes in villages, the whole community gathers to see what is happening. And so what we do, we use that as an opportunity. Once the home care program, palliative care, pain, ascites is all dealt with, we gather all the onlookers and give them knowledge about cancer, signs and symptoms, lifestyle, and then we administer the CBAC program. So we call this the PEP program. P for palliative care, E for early detection, and P for prevention, PEP program. And so through the PEP program, we pick up people with cancers. And, and then something odd happened. For all of this, one of my nurses came and asked me, sir, every time you go into a community, start a program, you work there for 4 or 5 years, and you create a system where the community starts depending upon you for their health care. And so Once the project is over, you submit your report and then you dust your hands and come off. Is that ethical? It struck me, what a important question that nurse has asked. I would have thought our ethics committee should have asked this question. So now all that we are doing, all the projects, when we start on the project, we start looking at continuity after end of the project. One of our objectives is how do we get the community to take ownership, because we as an institution don't have the resources to continue it. So it has to either be adopted by the government, which is a tall order, which will take time to get implemented. But the other thing, like what is happening in Kerala with the neighborhood network for palliative care, is that the community takes over. We are now experimenting in one of the communities to see if we can actually get the community to take ownership for promoting health and wellness in their communities, using the project as a learning ground. What we also realized over the years is very important for us to build coalitions with people elsewhere. And we are blessed in that every visitor who has visited us has added value to what we are doing. They've contributed their thoughts, their ideas, their criticism, their money, their time in many, and we've grown essentially because of so many people from across the world who have come across, who come visited us and taught us how to do things better. Dr. Purvesh Parikh visited us and helped start our relationship with the Indian Cancer Society. With my colleagues from Tata Memorial Hospital and elsewhere have come and added, in many, many ways. Dr. G. K. Rath came so many ways. And now, I never tire of saying that for any organization, fundraising is more important than fundraising. And then our whole, we say we are a pain-free hospital. So this whole pain-free hospital story started when somebody came on a grant to study opioid availability in the country. And so, as part of her thing, she was asking about pain. And so we said, we are a pain, we just on casual conversation. So then, we realized that we could actually make this a real possibility. And so we put boards all over the place in the hospital saying that we are a pain-free hospital. We actually invite our colleagues
I'm
to keep,
sorry.
yeah,
I'm sorry to disturb you, sir, but
yeah,
I think there are few uh, uh, people who are their mics are not muted, and I request Motorola Moto, who is it? Please, by mistake, you are made the host. Please make back us the host. IWSA HQ, please make us the host. Motorola Moto G34 5G. Will you please make IWSA HQ as the host? Sorry to disturb you, sir, but this is important. Motorola Moto. Okay, thank you very much.
thank you. So then we say we are a pain-free hospital, and we invite, visitors to actually go and ask patients in the wards if they are suffering in pain. We have a team of Australian physicians who visited us as part of a project called Hamrahi between Pallium India and the Palliative Care Association of Australia and New Zealand. And so they came on they came on 2 visits as part of the project, and then they continue to come year on year on year.
Uh, Please mute your mics. All the participants are requested to mute the mics. Is it Parul? Parul,
Yeah.
please mute the mic.
Mine is mute only, I think.
And the person with Motorola Moto, who is it? Motorola Moto. By mistake, that person is made the host and we are not able to mute anyone now. I'm sorry, all of you. Motorola.
Mini, give the
Okay,
number.
okay. No, sir. No, madam. Yeah, no, the person had made me the host. Thank you, sir. I hope it will not, we will not disturb you again. Very sorry.
No problem, ma'am.
Please continue. Please continue. Okay.
Yeah. So, uh, uh, so they come year on year on year, and then two of my colleagues actually went to Australia to attend the Palliative Asia Pacific Palliative Care meeting in Australia. And out of the two, one of them is our nursing supervisor, another Achun is a Rongmai Naga speaking girl who speaks a smattering of uh, um, uh, Hindi and Bangla, mainly Rongmai Naga. And so actually for her visa, we had to write out placards giving her standard answers for different questions. And uh, so when they went to Australia, so much of cross learning happens. So the Australian team was very excited in telling them, how they prevent falls because patients fall and then they break their femurs. So in our hospital, as I mentioned earlier, we have a policy that every patient will have a caregiver along with the patient. So Sarita did not know what falls was. She was asking the Australian team, "What are falls?" And then they explained that. So Sarita said, "We never see falls because we always have a caregiver." And so the Australian team actually published this in a scientific journal that, how a simple intervention can prevent so much of misery in elderly and sick patients. And then we are supported by whole lot of organizations across the country for patient care, for support for hospital infrastructure, for research, for cancer education, skilling, and in many ways it is. And then the National Cancer Grid. We are part of the National Cancer Grid, which is today a loose conglomeration of about 380 centers, cancer treatment centers, research groups, patient support groups. So many, everybody engaged in cancer care, and this number is growing. But there is unity in the strength in unity. As a group, we are able to group negotiate to reduce the cost of care. If I, as a hospital, negotiate for antibiotics or anti-cancer drugs, I will probably get a small concession or no concession. But when we negotiate as a group of 300 centers, the reduction that we achieve for patients is phenomenal. And then as a group, we have tumor boards which happen every week, several times in order to, there are centers which are like ours, back of boondocks with very little access to expertise. We gain from the expertise in different centers in the National Cancer Grid. We run quality improvement programs using all, and then we have, peer group reviews. So they visit, we were one of the first centers to be peer reviewed. And so they visited us, they looked at all the facilities. And so, collaboration helps a long way in bringing about uniformity of care across the country. And then all of this also helps us help our own colleagues in the organization grow. The organization will grow as our human resources improve, learn, and gain expertise and do better. So, in all these years, from the 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 years, the organization has come from a small 20 bed, 23 staff hospital. Today we are 146 bed, 480 staff spread over 5 campuses. But now our question is, are we sustainable and are we reproducible? And clearly, we are neither sustainable nor reproducible because all these years everything has happened on an adrenaline driven drive. We have somehow managed to make sure that we're able to provide service, but then how do we continue this in the future? And if we want to be a model that can be reproduced elsewhere, how do we reproduce it? And so it all comes down to sustainability in terms of human resources, in terms of social capital, in terms of the environment, and most importantly, economic sustainability. Now, of all of these, while on paper economic sustainability looks to be difficult, it is probably While difficult, it is probably the easiest of all of this because there is enormous goodwill across the country. There are large numbers of people with the CSR laws becoming more implemented. Access to funding is slightly easier today than what it was 20, 25 years ago. And then, and of all of these, I think the human capital sustainability is the most difficult. The philosophy of people, individuals is changing. Expectations of younger people is very different from expectations of a previous generation. And if you look at the measures that are needed to sustain human, we need to start from recruitment, team building, salary. So many things have to be put in place. And if you look at all the services in the hospital, to my mind, the only department that is sustainable is our nursing uh, facility. So what happened was several years ago when we were small, when I joined the organization in 2007, we were 20 beds. We had only 6 nurses, none of who was formally trained. And over a period of time, as we grew, we started getting ANMs, and when we got our first GNM, we actually celebrated. We came to a situation when we had about 35 nurses. The original 6 were still there, but then there was an advertisement in the government, and suddenly one night, overnight, from 35 nurses, we became 10 nurses. Our beds had grown, our services had grown, but suddenly the nursing staff all migrated because the government employment was much better than what we were providing. And so then we took a policy decision that always we will make sure that 50% of our staff strength continue to be the people who have very basic nursing training, but who are midwives basically, but who have been trained in the organization. Some of them are very good. My deputy nursing supervisor is a Dai who has grown in the hospital. Today she's working towards her GNM certification. But so these are people, so that is a system that can be sustained. But otherwise, fragmentation of healthcare, the idea of wealth creation, the idea of super specialization and all of this increases costs of care and is driving the whole profession towards non-viability. And so now, we are very deeply engaged in a thing, that why do values weaken over time? Our young, freshly trained new recruits without, often, I was given, even I used to believe that younger people who have not seen the struggle, but who have joined the organization when it is in a much better shape, don't have value. I used to believe that, but then I realized that is that is the last thing from the truth because young people come with ideology. They come with, a desire to change the world. They have stars in their eyes. But it is the leadership that causes diminishment of these values. So then question is, as people grow older in the organization, their families grow, they have children, their kids have to go to school. So real life needs, do they weaken? Maybe to some extent. But I think it is the leadership that compromises on the core values that results in. So I was in communication with we had a we talk about this, like a midlife crisis, that as an organization we are facing, questions, we are facing issues with values in the system, with the human beings that are working. So questions, why do our values? So one of my friends, Tarun George, is a physician at CMC who is right now working in the UK for his PhD, and he wrote a very, very instructive email to me, that we should look at what our weak links are. Why do values, have we started prioritizing revenue over patients? Sometimes when somebody requires an expensive treatment for a palliative care, and we take a decision that this money is not worth it, have we communicated it well to younger people? They think that this the immunotherapy is important because it will save somebody's life, because at that point they are not able to rationalize cost benefits. So did we take the time to explain to younger colleagues? Have we prioritized patient numbers over personnel well-being? When I say the last patient must be seen on the same day, does that result in a conflict at home? The doctor has promised to go out with his family, and have I kept him from his family time by insisting that they see every patient. Is, as time grows, there are people in the organization who, a doctor doesn't come on time. And I do overlook it because I think that person is very important. And so has has compromise on values for somebody who I think paramount has that eroded the core values. So, are the values given more priority over financial sustainability? Are we not able to make sure that our colleagues are financially well remunerated? Is so all of this, so he says, how can we balance competing priorities such as revenue generation and patient groups? How can we adapt to changing external circumstances such as technological advancements and demographic shifts? These are the things that are now, and so we came to a very basic question. What is the purpose of our existence as an organization? So all of us sat down and said our primary purpose is to promote health and wellness and happiness in our communities in an inclusive way. So, so which we have hospitals and satellites, we have a center for community oncology, we have education. We've also realized that when we talk of healthcare, it cannot be spoken in isolation. We cannot talk of healthcare without simultaneously addressing livelihoods, without addressing education. So, patient is treated for a cancer, he goes through chemotherapy, radiation, surgery, and at the end of it, he's unable to get back to productive employment. In other words, by treating and curing that patient, we've actually created a liability for the family. That is not okay. When we treat patients, we have to ensure that they or somebody else in their family is capable of shouldering the responsibility of earning livelihoods. And so, livelihoods is a very important part of healthcare. When we treat patients with in Assam, education is free. There are no education fees, there is no uniform fees, books are free, and yet, when a parent falls ill, the first casualty is the child's education, often the male child. Yesterday, I had a patient, daughter has dropped out of college because she has to work in an ophthalmic shop to support the family. One son has dropped out of college because he has to go and labor. And so often, despite the fact that education is provided free, the kids drop out of school because the breadwinner is ill, or the breadwinner has to take care of a family member. And so we have to focus on education. Healthcare alone, we won't be completing the story if we, and so these are what, and so we also wrote down our vision statement. We are a cancer center that will ensure that no individual develops a cancer that can be prevented, that no patient is denied appropriate care and treatment for want of resources, that no patient dies in agony and indignity because of cancer, and that no family suffers treatment induced poverty and grief. And we all wrote down as a unit what our core values are. We said our core values will be compassion, which for me is the most important thing. And then there is evidence-based care. We want to remain pro-poor. We want to be frugally innovative. We very strongly believe in teamwork, and we're very, very grateful for all the opportunities that have been given to us. And then, this is a quote that drives all of us. How much is care is enough for patient care? Time, sympathy, and understanding must be lavishly dispensed, but the reward is to be found in that personal bond which forms the greatest satisfaction in the practice of medicine. One of the essential qualities of the clinician is interest in humanity, for the secret of care of the patient is in caring for the patient. This was said by Francis Peabody in his lecture to the American College of Physicians in 1926, nearly 100 years ago. And, and this stands true today, and it will probably be true forever, because unless we care for our people, we cannot take care of them. We have to care about people to be able to take care of them. I had the privilege of working with two of the greatest physicians, I have ever seen in my life, Dr. Krishnamurti and Dr. Shanta. For Dr. Shanta, it was always everything for every patient. And for Dr. Krishnamurti, everything, the science of today is science for tomorrow. And having the opportunity to serve is a gift, but to be able to do so is a privilege. As a doctor, we are clinicians, we are healers, but we are also scientists. Cholera was discovered by the physician who found that all the cholera cases were around that pump. And then we are teachers, we mentor our students, but all of us as doctors, we are change makers, we are catalysts of better things to come. Thank you very much. This is thank you in different languages that are spoken in the hospital, in Khasi, in Bangla, in Hindi, in Punjabi, in Tamil, in Telugu. And so thank you very much for this opportunity.
Thank you so much, Dr. Kannan. I think all of us are just overwhelmed and quiet. We have just overwhelmed with the presentation. Thank you so much.
Beautiful. Yeah.
Param, if you
Yeah,
let me, I'll say a few words before.
yeah,
Yes.
surely, surely.
Yeah. So, Dr. Kannan, you have shown us that a big heart, open arms, open to ideas, bring in new ideas through literally using the word jugaad. And you have shown us how small observations, small implements, and identifying the very smallest of things that can turn a patient into a caregiver also can change your hospital. And also a mindset to join hands and to work together. And you are now addressing a very important question in your hospital, that you can provide the links from the treatment to the cure to a livelihood. I hope we could all do this in every aspect of our lives. Thank you so much. It's been wonderful listening to you.